So I'm going to call this meeting of the Board of Health to order. It is now 6:37 p.m. and we'll start with a roll call of board members. So Dr. Marla Gold.
Here.
Dr. Tyra Bryant-Stevens.
Here.
Dr. Scott McNeil.
Here.
Dr. Ana Diaz-Rue. Dr. Jennifer Ibrahim. And Dr. Amit Ismail. And then I'm here.
I have concerns about what's reflected in the chat, please. Ben, James?
Oh, yes, I think we may have.
Don't click that link.
No, I
Okay,
think
everybody, please. I don't know if we need to re-enter the room. What do you give us some directions here, please?
That person actually just left this, and I can prevent them from re-entering
Thank
if
you.
they show back up. But yes, do not click on the link in the chat, please. Thanks.
Yes, but
Dr.
I don't. I'm just going to say, I don't know if we should re-enter so that the chat goes away. That needs to go away in case anyone comes in this room later.
Let me see if I can delete it.
Do you have it as a direct message, Marla? Because that's what I have.
I do as well, yes.
So I don't think anybody can see that then.
Oh, he hit it to all of us individually.
Yes, interesting.
Woo. And so the name's probably not real as well, just because it's reportable, just to spend a second on this, right? Because we're doing official city business and that just happened. Okay.
Yeah, thank you.
Yeah, I guess we can pass that along to the Inspector General or somebody too as well. That's a first for me.
Yes, well, I've had that happen on a lot of my town halls, but never on a Board of Health meeting. So this is the point where I'll turn it over to Ben to explain the process, although I guess with no members of the public here, I don't know that you need to explain the public comment process.
I'll do it quickly just for a formality here, but good evening. My name is Ben Hartung. I am the Policy Advisor for the Division of Chronic Disease and Injury Prevention. If you'd like to present a comment today, you can do it using the chat feature or by emailing me at benjamin.hartung, the same spelling as my name in this Zoom meeting at phila.gov. And if anybody enters the meeting, I will restate that you are being recorded and that your participation constitutes your consent to be recorded.
Thank you. So have the board members had a chance to review the meeting minutes? And any questions about the minutes?
Move to approve.
Is there a second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Great. So for the agenda for this evening is very simple. Ben Hartung will be presenting the regulation relating to data collection about firearm injury survivors in violence prevention and intervention programs. So Ben, I'm going to turn that over to you.
Thanks very much, Dr. Bedegal. I will share my screen shortly. Let me just set up my presentation here. Can everybody see my screen?
Yes.
Yeah.
Okay, and I'm gonna stop sharing my video so I don't look like I'm staring off into ether, but okay. So this presentation was actually created by Dr. Ruth Abaya, who is my colleague in the Division of Chronic Disease and Injury Prevention. She is the Injury Prevention Program Manager. Unfortunately, she's unable to be here tonight because she is saving lives in her other job. She's an attending physician at the Emergency Department of the Children's Hospital of Philadelphia. And I helped develop this regulation and have participated in editing this presentation, obviously, but I don't have her clinical expertise or programmatic experience. So apologies if I'm unable to answer specific questions, but I think I should be able to handle this well. And just to let you know, these slides were actually developed from a presentation specifically about hospital-based violence intervention programs because our injury prevention program is a convener of a coalition of these programs throughout the city. But the regulation we'll be discussing is actually covers all violence prevention and intervention services in Philadelphia. And we just thought that, because we work so closely with HVIPs at the moment, that the purpose and need for this regulation is demonstrated through this presentation. So as the board is aware, and as citizens of Philadelphia are aware, firearm violence is a chronic problem here in Philadelphia. And this graph shows the last 3 years of shooting victim numbers as a running total. We don't have the 2019 numbers, but the 2020 numbers shown here are actually a significant elevation from the 2019 data. And so you can see that the 2021 and 2022 data, which are incomplete, show a continuation of this trend. And so the Philadelphia firearm violence has reached record levels and is appearing to stay there. So we've remained on this concerning trajectory, but the problem of firearm violence in Philadelphia is a chronic problem.
I have a quick question.
Yes.
We go back to that. So it looks like that it's seasonal in terms of the trajectory, right? Because with both 2021 and 2020, it starts out slow in the winter months, and then it really, really gets quick. It has a quick rise once it gets warm.
Yes, and I believe that is something that's seen throughout the years.
It makes
preceding.
sense. Yeah, it's
People
just
are
I didn't
outside
think.
more, and
Yeah.
and yeah.
Yeah, it makes sense. I just didn't think it was such an acute rise. I mean,
Yeah, it really is very noticeable, even on this graph, which doesn't show as much granularity as some of other data sources we could have shown.
okay, thanks.
So these maps here are actually from our injury prevention dashboard, which is available on the city's website. And it's on the graph on the left shows the percentage of people of all ages living in poverty by census tract in Philadelphia. And on the right, we have the count of non-fatal and fatal shooting victims in 2021. The injury dashboard actually is able to map other social determinants of health besides poverty. We have for this percentage of people over 18 without a high school diploma census tract, the percentage of people who are over 16 and unemployed, and the percentage of people 16 to 24, also known as opportunity youth, that are not enrolled in school and are not employed, also available. And they all show a similar overlap between the census tracts with these indicators of negative social determinants of health and firearm shooting victims. So the data that we're proposing to collect in this regulation that I'll present to you after this presentation seeks to understand how organizations that are working in these communities to address social determinants of health are reaching the community members experiencing that violence, and we're trying to understand how the violence can be addressed as a public health problem here in Philadelphia. So these graphs are just meant to demonstrate how much of a racial disparity we see of firearm violence in Philadelphia. On the left, we have shooting victim data for fatal shootings, and on the right, we have non-fatal data. And as you can see, it shows that the burden of violence, firearm violence falls overwhelmingly on non-Hispanic Black individuals. It's also notable that the majority of shooting victims suffer non-fatal injuries. So our program acknowledges this and wants to think about how we can respond to the walking wounded here in our city, those who survive firearm injuries. And it's important to focus on them for one reason, because it's been shown that people who suffer firearm injuries are at a higher risk of re-injury in the future.
It's also remarkable the male, female.
Yes. Firearm violence and violence in general could be yeah, classified as a male problem for sure. Not to mention the, the domestic violence aspect of it. So I mentioned before that this presentation was focused on hospital violence intervention programs. And one of the reasons why we've done that is because the number of ED visits that you see, emergency department, visits you see in Philadelphia mirrors the number of shooting victims. And we recognize that this presents an opportunity to meet patients who have survived firearm injuries where they are. That would be in the ED. And so the data on this slide really demonstrates that there's a large number of people who are seen through the ER, and HVIPs are present in these hospitals. And so this is really showing the number of people who could receive the services that we'd like to track through our injury prevention program. And like I said, the majority of shooting victims suffer non-fatal injuries. And this map here shows the number of level 1 trauma centers that we have in Philadelphia. And each one of these is part of our HVIP coalition that I mentioned our program as a convener of. And so across all these level 1 trauma centers, we see 84% of all non-fatal shooting victims in the city. And by our estimates, 77% of these shooting victims would be eligible for the services provided by HVIPs, not to mention services provided by other violence intervention and prevention models, such as Cure Violence and other victim service agencies, which I'll touch on a little bit later. But you can see that, Temple, Einstein, and Penn Presbyterian are seeing the vast majority of these victims. So this is, I'm sure the board members are aware, but if there are members of the public, this was meant to describe what an HVIP actually is. And it's really a model where interventions begin at the hospital bedside after a victim comes in. So they're followed by, a case management, and they can be connected to services such as community-based services, mentoring, home visits, follow-up assistance, and things of that nature. And the purpose of them is to address the social determinants of health. And I should have done this prior, but the definition of social determinants of health are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And that's the CDC's definition. So zooming out to the broader purpose of our data collection through this regulation that we're proposing, it's to help create an injury prevention registry. So we want to review all the known points of contact that we can collect for firearm victims in Philadelphia. And we want to do that, like I said, not just for HVIPs, but for all violence prevention and response organizations in Philadelphia. That includes the Cure Violence model and victim services agencies generally. And the goal is of this registry is to do a simple thing, is to look at the people who are injured by firearms and where they're making contact with these types of programs that are supposed to reduce their subsequent risk for re-injury and to provide them with resources to better their lives generally. So a further goal of the program is to try and determine how people are doing once they receive contact with these programs. And some of those outcomes that we are interested in investigating are whether or not they have future involvement with the justice system, whether or not they have future violent injuries, and just generally understanding the amount and type of resources that they're receiving through these programs, whether it be employment resources, mental health resources, what have you.
So I have another question, Benjamin. For these programs, I'm assuming they're evidence-based. Is that correct?
Yes. Well, they've there's been attempts to determine the outcome of these programs. And yeah, Dr. Bedegal, if you'd like to step in, I should have mentioned that Dr. Bedegal is actually still currently the acting director of the Division of Chronic Disease and Injury Prevention. So I'll turn to her in that
She
capacity.
does it all.
Hopefully not for very much longer. We're almost there. No, they are evidence-based programs. The piece of data we don't have is the Philly data. So, for the people enrolled in the programs, the evidence is there, and they're different, right? The Healing Hurt People program that John Rich has really created and championed is different from the programs at CHOP at Jefferson, but we don't have data on is the sort of the stuff that I really desperately want to know, which is what proportion of people in Philadelphia get offered one of these programs, what proportion get enrolled, how do they do, that sort of global, because it could be 10%, it could be 80. We haven't got an idea until we look at this data. So for what they do, yes, there's an evidence base. It's just that it's narrow because it's only looking at the population they're enrolling.
Oh, I meant the model. I'm sorry, I meant the model.
Yeah.
The model's evidence-based.
Yeah, it is. But keep in mind, they're using multiple different models. So John's model. Yeah.
Right. And so I guess the reason I asked that is because I guess we have some expectations of the outcome for the survivors or for people who interact with these programs, right? So are there benchmarks that we're gonna look at? Like, so for example, I have no idea what the rate of survivorship with, say, cure violence, but say it's the evidence says that it's 50%. Are you looking to benchmark 50% as what we're shooting for, or how are you going to use this information?
So there's multiple things that we want to look at. There's some very basic process measures about so who gets enrolled, who gets offered enrollment, who enrolls, do they stay?
Mm-hmm.
So if they get enrolled, do they find it valuable enough that they stay enrolled in the program? And then looking at rates of repeat injury, or, we know that this is John's work, but people who get hurt people. So one predictor of who goes on to shoot somebody is having been shot. So looking at recidivism as well. So there's a lot that we don't yet know about these. Does that answer your question?
Yeah, I think so. I'm always curious when we're building a registry, how it's going to be used. And, I think process measures are good, but if that's all we're doing, counting beans, the question is,
yeah. We want to know both. We want to know, do they go on to get re-injured? Do they go on to end up incarcerated for a gun offense? But more proximal to that, does the program even reach them?
Right. Okay.
So if I could, not sure how to ask it. The difference then, because on one hand, they're evidence-based, but it sounds, what I'm hearing also is some of the things to measure in a registry are trying to produce the evidence of an evidence-based model. So that's where I'm getting lost too. And I see Tyra smiling as well. So hang on. So it's for you get the data and sample ways that the data would have you make changes or do because the registry is a big deal. So if we're going to ask people to collect it and do it, then we have thoughts. I always think about HVIPs as key, but they're really secondary prevention, at least, because they're downstream already, because they're people who've been shot, and then trying to keep those individuals by addressing trauma over time, from racing out to shoot other people. So it's a little bit downstream, it's not all the way downstream. But if there's evidence that happens, then why are we looking at what to me is collecting evidence?
So there is evidence that the programs work. The evidence that we don't have is what proportion of people who are injured by a firearm in Philadelphia are even offered these services, let alone receiving these services. So that's what I meant about those process measures being so important. I think it's also useful, and I think all of the HVAPs who are participating in this collaborative are also interested in this sort of global information that could be gathered in terms of what happens next. But because we don't have any idea what proportion of people actually get this service at all, it's an evidence-based service. It is a thing we know we could do to decrease the number of people being shot in Philadelphia. It's absolutely downstream. It can't be the only thing we do, but it's an effective intervention. So that's why we want to have a sense of where are we right now in our progress toward making sure everybody at least gets offered these services. Because if we're at 20%, then we have to figure out how to get more resources into these programs and also figure out any barriers. Are there timing issues? Where are we missing? Versus, if we're getting almost everybody, next question is retention. Like there are all these steps along the way to make sure that this effective intervention does reach everybody.
Can I follow up? Understood. I hate to keep us, it's not about the program itself or its effective outcomes. Again, this is a registry. So just pushing a little bit further, I would naturally guesstimate that some of the reason why, for example, say you're capturing at hospital X, all the hospitals have these programs, at hospital X, 10% or 20%. But the reasons for that, the misses can be anything from they didn't want it to they're working internally. The warm handoff situation's terrible, to staffing, so that's why I'm lost on the registry where we collect a boatload of data. We have people all come into a registry. It's a wealth of stuff that we can use in many places versus things that will track on internal flow through the ER communications at the hospital, how a hospital CEO or CMO views the program. So I'm a little lost again about a registry versus
If I could,
operation.
So a piece of this is that the HVIPs now are part of a collaborative in Philly where they're all coming to the table. And it's useful to them also to be jointly looking at this, to be understanding the data across the city rather than just, it's their piece of the elephant, right? They see what's happening at their place. They can learn from each other. And I think one of the things that they would like to know is they can look at their own rate, right? But knowing what's happening somewhere else, and if somebody else is making more progress, being able to quantify that and learn from that. Okay, if it's 20% here and it's 50% here, what's happening differently? Because a lot of these barriers are the same everywhere, but somebody may have figured out an answer to that, or we think we've worked out an answer to that, but it turns out the data doesn't show that. And the other thing is that Scott is probably as aware of this as I am, having done a lot of safety net stuff. Maybe you all are. People don't necessarily go to the same hospital every time. They kind of go where they end up. So somebody could have been offered services at one place, gone to the other place. There could be crossover there.
Yeah, to me, that would be the only reason to collect the personal data, because certainly the hospitals could all report to you the numbers. There's no need to have a registry for that. Like they could say, we do 25, whatever it is. Like I know, for example, for the HVIPs at CHOP, I know how many people they served last year, right? And I know the denominator. But so I think every hospital could give you that.
Right, but you can't look at the other outcomes without the data. So you can't look at, did they get shot and end up somewhere else? And you can't look at, did they end up in prison?
Right. So, okay.
and we're also going to be able to cross-reference, because it's identified information, with the city's CARES database. I guess it's now called IDEA. So able to understand their use of city social services across time as well. So it's
Okay.
I guess the registry is more than just counting in a certain sense. Yes.
Yeah. So it allows you to track across systems. And now that is making more sense to me.
Yeah, and sorry that that Ruth's ER schedule is a little bit unpredictable, so we apologize for that. It would be better to have her here with us.
And I think some of these points are addressed a little farther in the presentation, I hope to. So this would be the goals of the coalition for HVIPs we're discussing, which is sort of what Dr. Bedegal has was just discussing. We want to understand the current rate of capture, and we want to talk about sharing the relevant outcomes like re-injury and connection to resources, and identifying barriers to recruitment, because we know that, you know, the 77% who are eligible for services, we know that number is much lower than who are offered or who accept services. And so then a further downstream goal would be to determine how best to support these violence intervention and prevention efforts. And that's determining, you know, the best way to advocate for local, state, or federal support if it's warranted. And there has been actually a lot of money flowing and proposed to be flowing at all of these levels recently because of the you know, obvious increase in Philadelphia, but also across the nation. I feel like firearm injury is getting a lot of press recently, unfortunately. So this is specific to the HVIPs, but each one of these trauma centers has a HVIP program. So turning to the aims of the regulation, the regulation itself will permit the sharing of data between HVIPs and other violence intervention programs with the health department. And I'll get into the specifics of those data points when we go through the regulation. But this regulation will allow us to understand how enrollment in these services might affect other various outcomes. And like I just discussed, we can link the people who are in the registry to other registries that the city has, like CARES. It can allow the city to track enrollment over time citywide. And it allows us to, you know, work with the coalition to support trauma centers in receiving resources that match patient needs. And Ruth is also working on establishing a coalition for other violence intervention and prevention models, such as Cure Violence, which is Philly Ceasefire. And there's also a READY program being developed in Philadelphia, which is based on the Chicago model of relentless engagement with high risk people who have been identified as high risk for firearm violence, and providing them with employment opportunities and cognitive behavioral therapy. So this is, I just want to emphasize, it's broader than HVIPs. And the last two data points here is we can continue to streamline violence prevention efforts, and the coalitions are intended to, you know, share this information so that resources can be used most effectively and efficiently, and most importantly, that there's you know, confidentiality protections built into the regulation for people who end up in this registry.
I'd like to, if I could, comment or ask a question here on this and the last bullet, Benjamin, anyone
Yes.
else? So, you know, again, I continue to look at no doubt about the need for all this information. Whether the registry is a vehicle for the information is where I get stuck. So a big question then is the builds on existing code requirement reporting for physicians. So what does that mean exactly? Is there already, I'm not familiar with it, you know, a form, an electron, whatever it is, where walk me through what we're asking clinicians or administrators to do at the level of the emergency room. What are we adding to their workload at the time that gun violence is rolling in?
So the code currently requires doctors who treat firearm injuries to report it to the city. I'll have to defer to Dr. Bedegal on the actual mechanism for that. So this requirement is slightly different that we're building into this regulation, and that it's not a requirement for physicians, but a requirement for service providers to report to us when they've interacted with a firearm injury victim.
So there was a law passed, and I believe it was passed in the 70s, that requires the reporting to the city of firearm injury. And technically, it actually requires reporting to the health department. In practice, people actually report to the police. But in my conversations, this is way back before we hired Ruth, that I was having these conversations with people. But I'm told that this actually occurs, that somebody gets on the phone and they call every single time. So that's happening. But Ben, can you talk a little bit about how the data, I think what Marla's asking is, are we creating basically more bureaucracy for people in ERs that they'd have to do, and how that would work? Or I don't know if you have a slide on that.
I don't have a slide on that, I believe, but it's my understanding that the way that this data collection will work is that it's not in the regulation. It's phrased that we're permitted to and authorized to collect this information. So initially, we're going to start out by requesting it of the HVIP coalition members who are already on board with this data collection because of Ruth's involvement with them. And what we would do is basically send a letter requesting that they provide the information about, and I should pull up the regulation at this point, but I could try and do that actually. Let's see.
And while you're doing that, it's maybe useful if I explain that this is a behind the scenes poll. This is not a reportable disease kind of thing where you have to fill out a form at the time. The other thing that may be useful to know about this regulation is it's something that the HVIP collaborative members felt would give them a little bit more cover to be able to share information they'd like to share with each other.
Not to take us off the direction of Marla's question, but just because you talked about this is again identified data and you talked about protections, is this some kind of opt-out? Is if the person that's been shot is aware of the data, this data being collected, and are they able to opt out and if they don't want to be put in this registry?
There is not a specific language about opt-out in the regulation itself. That could certainly be something that if the board members think is necessary, that could be integrated into our relationship with the violence intervention and service providers.
Yeah, I think unless it's a reportable disease, in which case they don't opt out, you do have to bring that up.
Yeah, that's why I just asked the question, because I thought you just said that this was tying into the reportable disease, but this isn't necessarily reportable. So this is
so because there's already a law requiring the reporting to the health department, it seemed like it does fall into that category to us.
Okay.
And I should say this has been through pretty extensive privacy review by the city, like for a couple of years, perhaps.
Yeah, and sorry, go ahead, Dr. Gold.
No, I'm missing something because once more, I don't question the need for the data. But the use of the word registry always has my sort of ears perk up because it's Board of Health reg creating a new registry. We're not taking an existing firearms registry and amending it. As best I can tell, we're not adding an extra question or 5 questions that we approve to an existing process. So I am missing something, and I freely acknowledge it could be my thick head this evening, and I apologize to my colleagues who are getting this, but the registry word, even if it's not a reportable or communicable, like I'm even surprised it would ever have to be an opt-out. It's a registry through Board of Health reg to produce a body of data. And I keep leaning on, is it, or is it that the HVIPs need to have more of something? Like, I almost feel like we're using a regulation and a registry to get people to figure out their flow in their hospital settings to use what they have, you know? And that's very different than the feel of adding a question to existing something, doing something that adds up to a whole body of data for the Department of Public Health to use as part of battling this epidemic of gun violence.
But the difference is if they only looked at their own internal data, they can't cross that with any of the other city data. So they can't look to see what other services the person might have received. They also, of course, can't look at what may have happened at other hospitals. So it loses a lot of the detail in terms of what we're doing globally to try to safety net people who are kind of in our highest bucket of risk. I mean, once somebody has already been shot, you know, obviously that can't again be our sole area of work, or we're going to miss a lot, but we know these people are at super high risk. So trying to figure out what's the network of services that they're receiving, what are we missing, to really try to protect them.
Okay. I totally understand the and appreciate it, and appreciate your patience with me this evening.
No, these are great questions.
No, it's nice of you to say, but I get the other databases and I get the ability to communicate. I, of course, also, when I hear the R word for registry, wonder, well, what else should be in there? What else? Because it's a very stylized thing to have a registry for the HVIPs specific to those programs. So that's what I keep getting tripped up on. Because I sort of am saying, well, what we're creating a mechanism for them to communicate, look at other things. At the end of the day, I just want to know that all of that says, okay, we're improving our program. We're somehow going to impact gun violence at the public health level. Yeah.
Right. And that's the goal. It might help a little bit to talk about CARES, which we also refer to as a registry, although it isn't really. CARES, the way I think of CARES is as a black curtain covered box where you can put things in and you can get things out that have been connected behind the scenes, but you can't look at all the data in that box. So it gives us a way of connecting databases that otherwise we can't connect. You know, childhood lead poisoning, for example, homelessness. There's a whole realm of city services that are in there where we can't, because it's sensitive data, get that and just have one of our analysts do that cross. But it's in the CARES registry, and so we're able to do this this kind of cross matching of data to know things that can be important for public health and for prevention while protecting data. I mean, CARES has very high degrees of security to it.
Okay, are there any more questions at the moment? Sorry. I can go back to my presentation for a second here, I guess. But we can, let's see where we are. We already covered this. Okay. So zooming out a little bit, the primary goal is for the HVIPs, and I guess I do want to stress that when we talk about a registry, we're really talking about having information about individuals' connection between services that are meant to reduce their risk for re-injury. So it's broader than, you know, hospital workflow. It's really about the whole city's ecosystem of violence prevention, I think, is how we envision using this data. So I don't know, Dr. Gold, if you have any, you know, follow-ups about the registry piece, but maybe that's an inartful word, but we are collecting names of people who have been injured. So it's a word that seemed appropriate.
Understood.
And so really looking at this goal, the meaningful recruitment piece is what the data is going to help us look into, because we're going to look at, you know, the time timeline they were involved with service providers, and we'll get specific programs that they were enrolled with the exceptions of mental health and addiction services, which were deemed to be, protected by privacy provisions. So the data collection really gets at this goal of understanding how the violence prevention programs are touching the lives of the people whose information we collect. And some of the, outcomes that we hope to investigate down the road using this data would be looking to see if there's a decrease in violence victimization for these people, a reduce of hospital recidivism, a reduction in their mortality, and general exposure to violence, and then post-traumatic stress symptoms is something that's been highlighted in the literature, but that's harder to get at because of privacy concerns, as I mentioned. A couple other outcomes we're interested in are, and these are services that are offered by the violence and intervention and prevention programs, or employment resources, housing access and supports, and any others that we receive from our questions of them. The regulation allows us to ask for basically the subject matter of the services that they're providing, and we can collect a sort of a universe of services offered. These are specific to the HVIP context, so I think I'm going to skip these. And that is the end of the presentation. And I will now pull up the regulation itself again.
And, one of the other kinds of data that having this would allow us to cross with is data from the medical examiner's office. So, if somebody's shot and killed on the street, they wouldn't necessarily end up at a hospital. The HVIP might not know, but medical examiner's office will know.
Okay, so this is the actual text of the regulation relating to data collection about firearm injury survivors and violence prevention and intervention programs.
Can people see the text?
Yeah, should I zoom in? Is that better?
Yeah.
Okay. So we start off with the authority that is provided in the Philadelphia Code, and it's been noted that there's some outdated language in the second whereas clause with regard to the reference to osteopaths. So I believe we're going to modify that for the final version of this, and I'll notify the law department about that, and it will be reflected in a draft. I think Dr. Bedegal, you might need to motion the board to approve that amendment.
Yes, and so we would be striking the words "or osteopaths," since osteopaths are physicians. Do we do that now? Or do we do that after the board votes on the regulation?
That's true. I guess you would have to, we would do that after the board.
Actually, you know what, I'm wrong, because we would have to amend it before they voted. Otherwise, they would be voting for something they don't. Okay.
True.
So do we want to make that change now, and then you can make a decision on the full regulation after Ben goes through it? Because we're fairly sure we would not want to keep "or osteopath" in there, I would think. Okay.
It's mentioned like in the fifth clause as well. So if we just struck out osteopath anywhere
Yes,
it's
thank you.
mentioned, and just say physician is, I think, the point.
Yes, thank you. So is there a motion to make those changes?
Make that motion.
Is there a second?
Second.
All in favor?
Aye.
Aye. Any opposed? Great. And we'll just plan to make that standard in any future regulations. All right, thanks, Ben. Do you want to keep walking us through?
Sure. So the second whereas clause refers to the section of the code that requires the reporting of gunshot wounds by physicians. And this 62024 is the authority we're using to require reporting of individuals who receive services that are not provided by a physician, but provided by violence intervention and prevention service providers. And the purpose of that data is to aid in the formulation and review of municipal programs for the promotion of the health of the public. The next series of whereas clauses goes through, excuse me, the basically the public health impact of firearm injury and explains the reasons why we want to collect the data that we are being authorized to collect by this regulation. It's noted in here that the information that we'll be collecting is protected by the Health Insurance Portability and Accountability Act, and there are confidentiality provisions in this regulation that I'll go through that help protect the confidentiality of the individuals whose data we are collecting. So we define data specifically in this regulation to be the name of the person who's been injured, their date of birth, the date the participant enrolled in the program offered by the violence intervention and prevention service provider, the date the participant was provided services, a brief description of the types of services that were provided to them, excluding any information about mental health and substance use treatment that was collected, and then the date the participant exited the program. So this data sort of gives you an idea of the length of time they were engaged with the program and the types of services that they received. We're defining a participant in the program as the actual firearm injury victim that had enrolled with the provider, and that a provider is defined broadly to be a violence prevention or intervention service provider operating in Philadelphia, including but not limited to HVIPs, victim service agencies, and community-based violence prevention and intervention programs who enroll firearm injury victims in their services. Section 2 is the statement of purpose. So we'll use this data that's collected through these providers to identify opportunities and risks related to the public health with the goal of preventing firearm injuries and death in the city of Philadelphia. Section 3 is the actual operative authorization to collect the data, and says that the health department itself will issue written requests to these providers, and those providers will provide the data points described there in section 3 and also in the definition of data above. And finally, there's the privacy and security provisions, and it's notable here that the safeguards for privacy include only allowing staff who have signed a confidentiality agreement to have access to this data, and that the data will not be shared outside of the Division of Chronic Disease and Injury Prevention itself without express written consent from the health commissioner or the city Philadelphia Law Department. Please let me know if you have any questions about the text itself.
I just had a question about the written request and how it's going to be returned. I mean, I guess you need to do a written request, but is there going to be like a central database, or how's that going to be collected?
I believe it'll be
the registry. It sounds like there would be something that people would enter into, but I don't know.
I'm not
So,
sorry, go ahead.
no, Ben, do you want to go ahead? I can fill in after if useful.
I believe it'll be sent through secure communications, most likely email, but I'm not 100% sure actually on that mechanism at the moment.
Yeah, I mean, it would have to be encrypted, whether they're going to use a secure red cap or have people send encrypted files. I haven't been told yet. We have a couple of different ways. We have hospitals submit, or providers at hospitals submit confidential data. So there are a few advances during the pandemic, and this is one of them. We have
Yeah,
a couple.
RegTep is definitely one of the options. I just don't know if it's been selected as the ultimate option.
Right. And this is all, this is a group that works very collaboratively. So I think a piece of this will be what's going to be easiest for the people who would be sending the data. My guess is probably an extract that gets sent rather than asking people to enter things into RegCap, but it's still to be worked out with them.
Can you just help me again, just understand, if we just walk through a scenario of a gunshot victim showing up at Temple. I understand the input of data. When somebody, for the violence intervention, is somebody going to then access this data looking to see if this person's in the registry? To see what interventions may have already been done, and or are they just inputting that the person is there for this time? So I'm trying to figure out at what point the data is being pulled out.
Yeah, I think it's being pulled out behind the scenes after the fact, rather than entered by somebody in the ER. And this isn't, we're using the word registry, but this is not the kind of thing where you could just log in and just take a look. So it won't exist in that sense. It'll be used for data matching and so on. But
yeah, I think that's the part, at least for me in primary care, thinking about the kids registry, that kind of thing. I'm kind of having a difficult time seeing how it's going to have point of contact, intervention versus. So it's really not going to be utilized that way. And
it's not.
Make sure I understand that.
Yeah, when we've used CARES in other ways, you can get a CARES match done. Typically, it's a few weeks, so it's not
right
there, patient in front of you. Yeah.
And this may be a really dumb question, but are gunshot wounds not reported through care anywhere? Like, can't the hospitals see it if they're part of that?
So one of the oddities of gunshot wounds is they're not necessarily coded in any kind of reliable way. I mean, I think this maybe relates to the whole federal atmosphere around firearms. I'm not sure. But when we've tried to do data pulls on gunshot injuries, it's very difficult to do. They end up coded in a whole lot of different ways, but not in a way that you can just do a, what's the ICD-10 for gunshot wound kind of answer. It could be a lot of things.
But it is included though. So, I mean, to your point about not knowing where they've been or if they've had a gunshot wound before, in Epic, which I think all the major hospitals have at this point, there's care anywhere. So I can look and see what happened at Temple. I can look and see what happened at St. Chris. Now I think St. Chris wasn't on it. So my question is that is that available or not now for gunshot wounds?
I think I'm not understanding your question there. You're saying there is a code in Epic for gunshot wound? Or
I mean, yeah, there is. I mean, yeah. Now my question is to the point that I think you made or someone made about if one of the reasons to have this registry is to really connect the dots, right? So if this person got a gunshot wound here, but went to, at Penn and then went to St. Chris, Einstein, and gunshot wound, the Einstein physician can see through Epic Care Anywhere, I think, is they can see that last encounter, right? At Temple or at Penn.
Yeah, if you're in systems that have Epic, you can do that. What you can't see is any of the other CARES data, and you can't see the services the person got.
Right, you can't see the services, right?
Yeah.
I get it. Mm-hmm.
Are there any other questions or things that you would want to talk through? So I feel like we probably should have used a word other than registry, because I feel like that does.
That's my facial expression. Yeah, because I'll ask this, what else was considered that led us here? And maybe Dr. Abaya needs to be here, but just what other ways have either been tried or were considered to collect this kind of data? Or is this the only vehicle that allows all of the other steps that have been outlined here to occur?
So
I'll
this-
just note that the word registry does not appear in the regulation.
Thanks, Ben. Yeah, so this really came from discussions with the HVIPs. And it seemed to the groups that were at the table like the best way, legally, because there is a law requiring reporting, they'd be kind of covered if they just reported now. But this allows them to report, allows us to receive data, has been reviewed by the law department for privacy protection. So they felt that it would be helpful. So there's not another option that anybody came up with to do what this does. And they're already looking at their own programs. So that, that's work they do internally, but this gives a sort of across the city look that otherwise isn't available.
Yeah, I ask it because, and I'm hung up on it, and I'll try and let the R word go. But similarly, I think of, okay, because what other programs could say, hey, if we put this up as a reg and could, as a regulation, we're in a public meeting, and we go this route, because maybe internally we've tried to get this information, from our superiors and we can't, but if the health department mandates it through this vehicle, now we're going to have what we need. So it might just be the way that we're looking at it or how I'm hearing it tonight.
Yeah, I don't think there's been any sense that any of us have gotten that the individual programs have difficulty getting information from their own institutions.
Okay.
That really hasn't been raised as an issue. The question was, everybody's in their own little silo. How do we connect the dots? How do we, there are things, because we're doing this homicide death review, there are things that have come up that we notice. When we did the initial data crunch in CARES, we found that every homicide victim had been arrested in the year that we looked at, every single one. And, so that's really striking, right? Like there was an opportunity to intervene, but on the other hand, thousands of people get arrested in Philadelphia. So it's not a small enough end for us to know exactly what we need to do to make a difference. So then that leads to lots of other questions about where are the other places where we can identify a super high risk group of people. And that's part of how we got to HVIP, because
Really helpful, just so you know.
Yeah. So some of the history, because we know that these are some of the highest risk people in the city. We know that these are evidence-based programs, and yet we know that people continue to get shot and die in Philadelphia despite the existence of all of these programs. So it was is this a reach problem? Is this, what else can we do? Because, numbers of deaths are going up, numbers of people being shot are not coming down, and our young men are dying. So that was kind of so each institution, I think, is actually very proud of what they are doing individually and feel like their programs are quite functional. So it's not that we're trying to find like, what's the flaw in this program, or this program's better than this one, or, it's more of how are we taking care of our city?
Yeah, and Ruth views the health department as a convener of all these groups moving forward, I think is the broader goal.
Yeah.
Understood, but if I were to just stop at what the commissioner has said, that actually was very, very, very helpful in this hour, because the bottom line is that we have a crisis of gun violence. And in order to have a more meaningful, complete picture that provides us with multiple points of intervention, we need to connect existing programs. And the only way to do that is to add this piece that brings in data from the HVIPs such that it can be run along these other data sets. You've made the case in 2 minutes, Commissioner.
I agree with you. I was thinking to myself, my brain already started going, okay, what were they arrested for? Can we start narrowing this down? So,
Right,
it's not
Right.
just any arrest. Was it arrest
right,
for,
So it-
carrying? Was it arrest for, dealing? I can see
Right.
now where, this could be helpful. We can narrow that end down somewhat, that denominator down somewhat.
right.
So I
And
think-
that's, sorry, go ahead.
No, so this is what was needed, at least for me.
Okay.
That, and just again, as I just put it, which is to say, okay, in the data that we know, the picture is incomplete. And to complete it, we have a way to expand it anyway. We have the data, but it's not connected. And the only way that we can open up the gate and connect it in is this. This is the vehicle. Then I understand why it's in front of the board and why it has to be done this way. So I appreciate what you've just said.
Great. And I really appreciate what I'm hearing from the board, which is we only want to collect information that we need, and we want to respect the privacy of each of the people concerned here and be really, really careful about that. So I think that is a really important aspect of this as we do this work.
Yes,
do you
and we
have-
always want to limit burdens on the healthcare provider. So
Absolutely.
That's,
And fortunately for us, Ruth is an ER doc, so she knows just how busy they are, and we do not want to make people sit in ERs filling out forms. So, are there any other questions at this point? Is there a move to pass the regulation as amended to remove the language about osteopaths?
So moved.
Is there a second?
Second.
All in favor?
Aye.
Any opposed? Thank you all. I have to look at my instructions for a second. I'm sorry. All right. Ben, is there anything else that we need to do before we adjourn this evening?
There is not. Thank you very much, board members.
Okay. Thank you all very much. It is 7:39 p.m. We are adjourned. Have a wonderful evening and happy Juneteenth.
Yes, thank you. Marla, have a nice vacation.
Yeah.
thank you.
Right.
Take care, everyone.
Bye-bye.
Okay.